If you are tired of being told to just lose weight, get back on the pill, or deal with missing periods, welcome. You are finally in the right room to get the answers you've been looking for. I'm Dr. Angela Potter, and this is the PCOS Lab. Together, we find the root causes to help your body work as it's supposed to and restore your cycles from the inside out. Let's head into the lab. Have you been told that IVF is your only option or the absolute final answer for your fertility journey? And does that not really sit right for you? Well, what if less is actually more? Today, I am sitting down with Dr. Erica Bove, a double board-certified reproductive endocrinologist and fertility specialist who does things a little differently. Dr. Erica is pulling back the curtain on the conventional fertility industry to explain why so many women are rushed into these advanced procedures that they might not even need. So if you're ready to hear a refreshing, holistic perspective from a medical doctor who truly listens to her patients' goals, you are in the right place today. Let's head into the lab with Dr. Erica. Dr. Erica, hello, welcome. I am thrilled to have you here today.
Thanks, Dr. Angela. It's so great to be here.
Yes, so just in the pre-show, oh my gosh, we've been talking about all these items we want to talk about, and I am so excited to get into it. So we were talking about how, you have got many stories of women who have gone through IVF and then you just realize maybe that's not the path forward. And
yes,
I'd love to start there because so many people think that IVF is kind of the be all end all or, the final answer in IVF.
Yep.
So can you share a story about how that looks different for people you've seen?
Absolutely. So I'm going to share a story from early in my career. I remember I was a new attending. This woman came into my clinic and, very tragically said, I went to IVF. I didn't really have a diagnosis, but my husband was in the military, wanted to get pregnant as soon as possible. So we did IVF. They put in 2 embryos. I got pregnant with twins. I had a terrible second trimester loss. Both babies passed away. And, I really want to grow my family. We don't have any embryos left. So these are stories I hear frequently in my practice, right? And so you're thinking, okay, well, twin pregnancy, higher risk. She had these losses. She has this trauma. And then I started asking questions. I was like, okay, so tell me about your periods. Oh, they've always been irregular. Okay. So tell me about, do you have any acne, any extra hair where you don't want it? All those questions. Oh, yeah. But I'm Mediterranean, right? They just said that was normal. I'm like, okay. I'm like, well, how did IVF go? I got 35 eggs and I got kind of sick, but they said that was part of the process. So as kind of I'm sure Dr. Angela, you do this too. As you're listening to the history, you're kind of your spidey senses are going up when you hear different things. And my alarm bells are going off oh my gosh, this really sounds like PCOS. And so I said to her, I was like, okay, let's do an evaluation for infertility and PCOS. I'm wondering if this might be part of your diagnosis and what's going on. So lo and behold, I diagnosed her with PCOS and I said, I'm not sure that IVF is the answer for you. Sometimes less truly is more. And what can we do to understand this better? And you have to establish trust because that's not conventional. You're taught there's a stepwise approach and IVF's the best and everything. So she trusted me. And then I remember I gave her letrozole and that was our entry point. She got pregnant the first cycle with a singleton pregnancy, delivered at term, and was just so grateful. And I think that's a story that highlights IVF is not a benign procedure. There are complications. Sometimes twins happen. Twins are higher risk pregnancies. You can get twins outside of IVF, of course, but this woman came to me with this horrible history. And for her pathway to becoming a mom was really less is more, taking a step back, understanding that she actually did have PCOS. And that was part of why she was in a fertility office in the first place.
Wow. And, I think so many people listening are going to be like, what? There's this MD telling me that perhaps there are different things other than IVF. And so thank you so much for sharing that story.
You're welcome. Even a dear family member of mine came to me a few years ago and said, just for disclosure, my sisters and I all have PCOS, everyone's in our family, et cetera. Family member came to me saying PCOS, mild male factor. My doctor is recommending IVF off the bat. And I was like, show me the sperm report. I want to look at it. And so I looked at it and I was like, I think IUI is like going to be fine for you. Like a little letrozole, a little IUI. Like I'm not sure we can reserve IVF for the future if that's necessary. Now like 3 children later, here we are. So I think you really do have to say sometimes it's like that impatience, like we wanted to be pregnant yesterday. And what we're taught
Yes.
is, well, IVF is like this percentage, more successful than IUI or trying on your own and all those things. But like I said, number one, IVF is a lot to go through emotionally and it's expensive. And I think a lot of the people who do IVF so quickly don't necessarily need it.
Yeah, can you talk more about that?
Yeah.
Because so many people in my community, the women that are coming to me, are saying, I've been told from my doctor that IVF is the only approach and is the only path.
Yeah.
So, I'm sure they would love to hear what's the philosophy from an MD who thinks a little bit differently than that.
Yeah, absolutely. And I mean, I think holistically, and there's this whole field of like restorative reproductive medicine, and it's gotten very political, but I think we should all be doing restorative reproductive medicine at the core, which is really restoring cycles, restoring natural fertility whenever possible. So IVF was actually developed, 40 plus years ago because people had no fallopian tubes, right? Some people had no fallopian tubes, and IVF was created as a way to overcome that. What we do in IVF is we take about 2 weeks of time. We stimulate the body with concentrated hormones, so follicle stimulating hormone, luteinizing hormone, usually an ovulation blocker. People are coming into the clinic, every other day for 2 weeks, which can be very inconvenient, especially if you don't live near a clinic. And then you don't really know when your egg retrieval is going to happen. And so like you're kind of on pins and needles. Do I cancel work? How do I live my life? You get basically 2 days of notice that your egg retrieval is going to be 2 days later. And so that process happens. We take the eggs out through, a transvaginal ultrasound with a needle attached, take out the eggs under anesthesia. And then the lab gets those eggs. We then have a sperm source. The lab will fertilize those eggs with sperm. Not every egg's mature. Not every mature egg fertilizes. Not every embryo makes it. And sometimes, especially for people with PCOS, I see a lot of attrition and some people end up with no embryos at the end of the day, even with like 20, 25, 30 eggs. So your egg reserve is great. But I think that there's a lot to be said about PCOS and egg quality that we don't talk about enough. And so when I see somebody in my practice, first of all, I want to understand if somebody does have PCOS, because I think that a lot of times people are diagnosed with it who don't have it. And more often, people who actually do have it don't have that diagnosis, and it would really serve them to have that diagnosis. So we have to be precise at the beginning, right? And then we have to ask ourselves the question, okay, well, is there egg and sperm exposure? Unless somebody has no tubes or like very low sperm counts, IVF is really never my first recommendation because it just doesn't make sense for most people, right? So that I just wanted to put that out there. So I always take a menstrual history. You say there's two sides of the coin. On one side is the ovulation issues. On the other side is the metabolism. They go hand in hand. I'm sure you hear this in your practice. People say, well, when I was 16 and I was on the cross country team and athlete, I had regular cycles. And then I went to college and gained 30 pounds. And then my cycles got irregular. Or people lose weight for their weddings and then they gain weight. The weight piece, obviously people have lean PCOS. That's a piece we have to think about. But a lot of times really understanding the weight journey as part of somebody's story can be really, really empowering and informative. So really listening at the beginning and understanding, who is this person? What have their periods been like throughout their life? Do they struggle with extra hair or acne? Do they want to have children now? Do they want to have children later? All these things are integral to the conversation. And so once I have an understanding of that with the lab work and confirm a diagnosis of PCOS, then I talk to people about their options. I say, okay, we can work on restoring your natural cycles, and that takes a little bit more patience, a little bit more time, but is really your best way to ensure having one baby at a time. I mean, ensure is a strong word, but maximize the chances of having one baby at a time, because anything I do to you is going to increase your risk of twins. And so we want to give you a healthy baby. And the best way to do that is one baby at a time. So that's the first thing is restoring natural cycles. And that can be through exercise, supplements, weight optimization, diet, GLPs. There's been a lot of data recently on GLPs and PCO. There's so many ways. Sleep apnea. Gosh, eggs like oxygen, surprise, like all of our cells like oxygen. Why wouldn't our eggs like oxygen? We need to be breathing at night. So really, really holistically looking at somebody's health and trying to optimize that in the vein of optimizing natural cycles. Because I say, if you're having 3 periods a year, that's not fair. You're not having regular sperm and egg exposure. That we can do something about that. And I mean, most people don't want to have to see a fertility specialist. They want to get pregnant at home if they have a sperm source and they're able to do that.
Yes. Wow. Okay. That just feels like such a breath of fresh air,
Yeah, thank
honestly,
you.
to be like, okay, let's look at what's going on first and then use IVF if indeed at some point it's indicated or wanted.
Sure. I mean,
Yeah.
there's also like, letrozole is a fantastic medication. It's an oral medication. The side effect profile is very, very, limited. Like people don't usually have side effects on letrozole. And that can either help augment somebody's natural ovulation or even help them to ovulate in the first place. And so that's a medication that I use a lot. If I start to use it and it's not working, sometimes we say, okay, let's optimize the health and not just, go up and up and up to IVF. And so or sometimes people do an IVF cycle and it's really not looking good. And then I say like, whoa, 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 like let's take a step back and really look at your life. Because IVF, it doesn't overcome everything. And a lot of it is the inflammation and just the pathways are not right. The physiology is not right in the body. And at the end of the day, we want to give people the best shot of a healthy baby.
Yeah, I love that you mentioned that because I think infertility in many areas of medicine, but we get very one track forward, like, okay, IVF, one answer to fertility. And
Yep.
for you to be saying, no, we've got to look at all
Yeah,
these different parts of the body. Yes.
totally. Totally.
So when you have PCOS patients in particular coming in to see you, what are some kind of misconceptions? What are some big themes of misconceptions that you hear about and see?
Yeah, I mean, I think we have to realize that PCOS, it's a diagnosable illness, and so I think a lot of people, especially if PCOS comes with carrying extra weight, like a lot of people are shamed, and I think that that's something that we really have to look at because it can affect self-concept. It can, put the onus on the person. Both infertility and PCOS, like, are diagnosable disorders, and we have to say, okay, like, would you think about like diabetes this way or pancreatitis this way or appendectomy this way? Like we need to really think about the physiology is altered. There's hormone imbalances. There's things we can do about it, but like taking the blame off of the person, I think is really, really important to do. I think that another misconception I see is that people have to rush right into some sort of treatment. I maybe more vocal about this than most, but usually when I talk to people, it's not just the infertility, it's like the whole way that PCOS affects their self-concept. It's body image, it's, whether it's extra hair or the new ESFRI guidelines, which I love to talk about at the European Society. They talk more about the holistic approach and sexual function and mood disorders and all the things that most people don't even scratch the surface of with PCOS, that this is a disease that affects people's quality of life and how they walk through the world. It's not just like, oh, I can't get pregnant and let's fix that problem, right? So a lot of people want to feel better in their bodies, in their lives, and I tend to start there. I mean, I will say, being very frank, like that doesn't make a lot of money, right? Like if you think about, the fertility industry as an industry, what makes the money is the IVF. And so I think there is a lot of financial push for people to do IVF for financial reasons. But if you actually look at it, sure, if somebody needs IVF, then that's a tool. But a lot of what we can do is going to happen outside of those more advanced technologies when we can address the root causes of what's really going on.
Yeah, I'm so glad you brought that up because I'm talking to people all the time who are saying, but I'm also fatigued and I'm not sleeping well and my
Yes.
digestion's weird. Like, are these connected to PCOS or are they not? I just don't feel good. And it can be really confusing.
Yeah, it can be. And I'm
Yeah.
sure you've seen, I mean, when people, I say, you can make an investment of about 3 to 6 months and see how that goes, and then come back and, obviously not like see you in 6 months, but like, let's see, give this a good college try at this. People come back. I had one lady who came to me and was like, I don't even care if I have children because I've finally addressed my eating disorder that I didn't even know I had. And I'm have a good relationship with food now. And like, I mean, ultimately she was successful in building her family, but she said like, I did not realize how dysregulated I was until we pulled up the hood of the car and started looking at things. And so I think people want to feel better first and foremost. And hopefully having a child is part of that if that's their vision. but we have to kind of take a step back and look at the big picture if we're really going to be doing justice for our patients. Yeah.
Yes, I love that. And I talk to a lot of people who are saying, are in that space where they're not feeling good and they're having all, this whole list of symptoms. And of course,
Yeah.
PCOS is at the forefront. Fertility is the goal. Pregnancy is the goal. And they'll go in to talk to their doctor and they feel really dismissed, right? They're
Yep.
told, oh, there's nothing that we can do for you, or, oh, IVF is the only option for you, or a variety of things that they're hearing. And ultimately they're walking away feeling, I don't feel heard. I feel like just completely dismissed and that
Yeah.
nobody's actually advocating for me. And this is my
Yeah.
doctor that I'm seeing. So I'd love for you to touch on that. Like, how can these women who have this goal of raising their families, how can they advocate for themselves and what to
Sure.
do in those situations where they feel dismissed?
Yeah. So, I have a whole podcast episode on like balancing trust and advocacy because I think that's one of the hardest things that we can do is like knowing when to lean into the care and like knowing when to speak up. But I think, some of the things that I talk about are like, okay, does your doctor know the details of your care? I think that a lot of fertility has been like, okay, there's this protocol and that protocol and this protocol. And sometimes the doctors themselves aren't even directing these protocols. It's more run by like nurses, which is, I understand practices work that way, but I think that that notion of like personalized tailored care is, does somebody know the nuances of your care? Do they know why you meet the criteria for PCOS? Like asking your doctor, why do you think? And I had a patient ask me this recently because I put it on an ultrasound report and I was like, thank you for asking because all my notes say question PCOS and I will modify it, to that. That's a perfect example of like how my own patient was like, hey, I'm not sure this is certain. And can we like, take a step back? I'm like, right. Recurrent pregnancy loss question PCOS, right? That's a much different situation. So I think asking the question of like, okay, why do I meet the criteria for this? We know there's a Rotterdam criteria that involves ultrasound criteria. It involves some sort of evidence of clinical or biochemical hyperandrogenism, which is like that sort of extra male hormone in the body, and then also the cycles. And so you need 2 out of the 3 of those for the listeners and cross a whole bunch of things off the list like thyroid and prolactin abnormalities and, even rarely tumors, even though I've only seen a couple in my whole career. Like there's a whole thing that's why we do the workup is to make sure it's actually PCOS and not a lookalike. So your doctor really should be able to tell you like, why do you meet criteria? Like what of those things do you have? What's been crossed off the list? Just for the clarity of like, okay, I know that this has been looked at. Also, like, are people looking at the metabolic side of this coin? Like have somebody checked my A1C? Has somebody looked at my lipids? Has somebody looked at, all the different parts of this that are pro-inflammatory and, making me, I'm eating 1,200 calories a day, but I'm still gaining weight. I'm sure you hear this all the time. Like, what about that metabolic side? Can we do something about that? Because I think that when we can start to budge that, a lot of times we can start to budge the needle on the fertility. So first of all, asking those questions about the diagnosis, super important. And then asking the question, okay, so like, can you walk me through my treatment so far if you've had treatment and like, okay, you've done 4 letrozole cycles, you made 1 to 2 follicles each time. This was your lining. You did the trigger shot. This was the outcome. If somebody's gotten pregnant on that protocol, I'm like, great. I got that. Not great because I've had a miscarriage myself. I know how devastating it is. But like from a fertility standpoint, like, great. I know how to get them pregnant. I don't think we need to rush to IVF just because they've had one miscarriage. They've gotten pregnant with this protocol. And so let's keep going on that protocol, maybe with some alterations. And so those are the sorts of high level questions that you should be able to have with your care team. Now, if somebody really does recommend IVF, I think the question then becomes, tell me why you think IVF and not something else at this point. I will say there's a whole bunch of people where if they've done a few cycles of 1 to 2 follicles with letrozole and it hasn't worked, I then start to think about them as maybe more unexplained infertility. Okay, now you finally had egg and sperm exposure, but it's not working. And so how can we maybe up the ante? Get you to ovulate 2 to 3 eggs at a time. Maybe put the sperm inside, increase the chances. Maybe somebody has undiagnosed endometriosis at the same time, and that's the standard of care for that treatment, that pathway. And so, there's a lot of different step up things we can do to try and optimize. There's a lot of steps in between, like quote unquote, doing nothing and IVF. And so if somebody says, listen, you've had this many cycles, this is the response, this is what I'm seeing, or maybe your partner has a very low sperm count, and I think that that's really going to help maximize the chances of the egg and the sperm meeting each other, that's a very logical explanation for why IVF makes sense as the next step. But if it's just because, well, it looks like your AMH is high and you're a good candidate, I bet we get a lot of eggs and all those things, that's not really sufficient to warrant, like, you can do all, you shouldn't try all these other things. Hey, if you're 40 and you have PCOS and you really want 2 kids, okay, fine. Maybe that's going to be a good pathway for you to have more than one child at an advanced age. But these are the sort of nuanced, tailored questions that you should be able to have. And if you're not getting that care, you need a second opinion.
Thank you so much for bringing that up. Well, first off, I think those questions are really great for the listener to be like, okay, this is what I can talk to my doctor if I'm not feeling like I've got that communication going. And then that really important point that, yes, you can get a second opinion. It's not that you just have to continue feeling like you're not being heard. It's completely normal to go get a second opinion, switch doctors, go find somebody else.
Yeah, absolutely. And I think that, it's not always a good fit. I just think we have to normalize that when we're first dating in our lives, like we don't usually marry the first person we date necessarily. Like it's not, I don't think you should go around like 10 different consults, right? But I think at some level, feeling heard, feeling seen, somebody understanding the details of your care. And if you are a person who does prefer a more holistic approach, then find a physician who is a more holistic physician, because I think that's going to just naturally be a better match, right? And so if somebody tells me in the beginning, hey, I am telling you, I do not want IVF, I put that in like bold capitals at the top of the note because I want myself to remember that. I want my whole team to remember that. Like, this is a person who's really hoping to get pregnant outside of IVF. That's really important. So like, let's optimize every single tool we have before thinking about that. Or maybe some people say, I would not even consider IVF. I want to give this a try, but that's where we draw the line. And sometimes people change their mind over time, but sometimes they don't. And so I think understanding where people are at the outset and what their goals are is incredibly important to set the stage. And I think some physicians are more receptive to that than others. And so I think even in that first encounter, asking those questions, like, how do you feel about a holistic approach to PCOS? And then those sorts of things. Like sometimes from my perspective, sometimes if somebody does want a biological child, we do need to go to that extra step. But I think the point is, and I hope this is clear, that like it really is usually not first line.
Gosh, I can tell, Dr. Erica, that you are a doctor who listens, and it's clear that you keep your patients' goals front and center. And I think that's incredible.
Thank you.
Can you talk a little bit about navigating the fertility roller coaster? And, there's a lot of triggers that come up at different appointments, or journeys look so different. What would you say to someone who is going through just feeling like they're going all over the place with all these treatments?
I think it's a great question. I think that one thing that we're not taught to do is regulate our emotions, right? We're sort of taught to compartmentalize, or like, just get through this part of your life and then address this part of your life. But one thing I help my patients and my clients with a lot is like that emotional regulation piece of like, how do you feel the feelings? Like, if you get a negative pregnancy test and you were hoping that this would be the month that you got pregnant, that is a disappointing result. And so how can you feel the sadness in your body, not dwelling on the sadness, but really processing, metabolizing, digesting that emotion? So it takes about 90 seconds to process an emotion, but unless we're taught how to do that through our bodies, if we're going to stay in our minds and just, stay kind of not at the level where things can integrate. So I think learning how to feel the feelings is really important. I think that understanding what our triggers are can help us prevent them. Not 100%, but a lot of like 80% of trigger management is actually kind of understanding what they are and saying, okay, well, maybe I'm not going to go to my cousin's baby shower this year, or maybe I'm going to sort of have certain parameters before I go to these holiday parties and preempt my family members by texting them that I don't want to talk about fertility. Like all these different things that are in our control. I think understanding what our triggers are and either removing ourselves from the situation or processing the trigger in real time, understanding how we can heal those wounds from the inside out, because our triggers show us where we need healing the most, right? And so a lot of this is saying, okay, trigger management. And then I also think that there's a lot of emphasis on like each particular cycle, like each menstrual cycle, each, embryo transfer, whatever it is. And I think that we put so much weight on like the microcosm and we don't trust the overall process. Even when I start somebody on letrozole, I say, listen, this only has a 10% chance per month of working. But if you do this for up to 4 cycles, it's cumulative. So 20% with the second cycle, 30% with the third cycle, 40% with the fourth cycle. Those numbers sound better to my mind. So I'm like, we're not going to say this isn't working until you've done at least 4 to 5 cycles of this, and then we can reassess. But the way our brains work is like, oh, I'm intervening, it should work. And then there's this crash. And so I always tell people, especially with the first letrozole cycle, like, be prepared. Hope that it works, but there's a 90% chance it won't with the first cycle. And so we're investing, a 4-month period of your life in this, and I am here. We're going to make that appointment. We hope and pray that you're pregnant. If you're not, we cancel that, if you're not, we keep that appointment. If you are pregnant, we cancel that appointment. But I am here for you. We're going to figure this out. And so I think releasing those timelines is also really important.
Yeah, I love that. Just understanding your own triggers, and so then you can avoid them, and communicating with people around you. Yeah.
Yeah, or removing yourself. I mean, like, if somebody's in a yoga class and the instructor happens to be pregnant, like, that can be really hard to
Yeah.
sit in that class for an hour. And so, like, just giving yourself
Mhm.
permission to say, like, oh, I didn't realize this was I'm feeling kind of uncomfortable today. I had intended to go to this class, but I think I need to leave. Like, giving ourselves
Mhm.
permission to remove ourselves from situations. We can't prevent every single trigger. We can try, but like in real time, just giving ourselves the permission to do what we need to do. I'm trying to think of other examples of like in real time, if somebody asks an insensitive question, like, gracefully exiting the conversation. There's so many different things we can do in the moment with triggers. And, it's hard because it's hard when they happen. But I do think that just navigating life that isn't such a landmine of triggers, I think it can be helpful. Yeah.
Yes, yes. And I love that you were talking about that with the letrozole cycles. It's like, okay, let's be realistic about the first cycle and then look at it actually globally over 4 months. Based on what you see in your practice, is there like a typical timeline that you see? Or is there 4 months or 6 months? Is there kind of a sweet spot that you see?
Yeah. I mean, I think it depends on what people are doing. And I know that like
Mhm.
you have a very good track record, right, of helping people to ovulate regularly and that they get pregnant fairly quickly after working with you, which I think is amazing. So I think that if somebody is not having egg and sperm exposure, meaning they may be living their lives as a couple and having sperm exposure, but if they're not ovulating, that's not going to give them a chance to get pregnant that month. And so I think the first step is saying, okay, if you're coming to see me and you haven't had a period, gasp, in like 5 years, obviously people should be having periods every 3 months if they don't have progesterone exposure. But if somebody truly, I mean, I see this all the time. People have years and years. Oh, it's been years since I had a period. I'm like, okay, that counts for you emotionally, but that does not, you're not on the fertility clock because you probably didn't ovulate during that time. Right? It's just
Right.
not fair. And so
Mhm.
I like to see that people have like a fair time period of egg and sperm exposure before we even start to get like quote unquote worried, because that's half the battle is saying, well, you're not ovulating. And one thing I will say, Dr. Angela, and maybe you see this in your practice, I do see a very high percentage of people who have like a touch of PCOS and a touch of male factor. And it's not like the
Mhm.
people find each other, but I think those people find us because there's 2 levels of redundancy are knocked down, right? If somebody ovulates 4 times a year and the sperm are perfect, then great. One of those good sperm is probably going to slip through when they're ovulating and like fantastic. But if somebody, is ovulating every single month and the sperm are terrible, that's probably not going to happen either. But if somebody has like mild PCOS and mild male factor, that often will keep people under the subfertility threshold. So I really wanted to share that there's a lot that can be done with male infertility as well. And a lot of
Mhm.
times, like people are rushed to IVF because of male factor, but we have a whole field of reproductive urologists. And so what that involves is like not just one semen analysis, but 2 semen analyses to understand, are these data consistent over time? If it's abnormal twice, then doing an evaluation, which involves hormones for the man, just as we do for the woman. And I think men, not to stereotype, but I think women, especially when it comes to fertility, often take like a more active role in their care. And I think we need to empower the men to do the same thing, to say like, it takes two, this is your responsibility. And, for many men, they've never taken ownership of anything in their health and their lives yet. And some men have, but some men haven't. And so just really emphasizing the importance of getting these tests done. So hormones, before 10 a.m. and then even a consultation with a reproductive urologist, because I can't tell you how many times somebody's had a varicocele diagnosed, or maybe they were smoking pot 3 times a day, which is a huge problem for male infertility. And we, help them clean up their lifestyle and the sperm improved to the point where, oh my goodness, now we help the woman to ovulate and then the sperm are better. And then voila, they get pregnant. And so I really think, again, back to this like restoring natural fertility, there's so many things that we can do. And, to be frank, a lot of it is lifestyle. And that's hard because I think if we're treating anxiety with marijuana, we have to figure out then what to do with the anxiety. But we really have to look at the whole picture and like how we're living our lives. And like I said, optimizing things on both sides so that we're not just like, are we helping the woman to ovulate? But like, when they get together at home, is that going to be an optimal sperm sample, and optimizing things on the male side as well?
I love that you brought that up because when we look at statistics, male infertility and female infertility, it's about the same, isn't it?
Yeah.
It's
Yeah.
30%, and then 30%
Yeah.
is unknown.
Yeah. We say
And
about 40% of infertility has some combined male and female factor combined.
yeah,
Yeah.
combined.
Yeah.
Yeah. And I think, it is really common for us women to think that, oh, it's our fault, or, there's more hormones going on, more organs, but actually it's about a similar percentage for the guys.
Yeah, it's really
Yeah.
interesting. And I think that men, again, not to generalize, but I think a lot of men have like a sense of pride, and like it's like it almost feels like a cut to their manhood if there's something wrong with their sperm.
Mm.
Just the way that men are wired to protect and all these things. But I think just sort of reducing the stigma for men to say, like, listen, I see this all the time in my practice. Like, there's things that can be done. We're going to optimize your sperm. Like, it's okay. But I do think that is a barrier that I see in my practice is like, how can we support the men in this process? Because they are generally wired differently than women. And I think we have to acknowledge that.
Yes. Another thing that I really resonated with is you brought up that, if somebody has been trying to get pregnant for the past, say, 5 years, but they haven't had a period, they most likely haven't ovulated in that whole
Right.
time.
Right.
So, of course, that's an intense emotional journey. But when we're looking from the medical side, it's like, but you haven't had that egg sperm exposure. So this is not, even though it's been so long, from our perspective, the medical side, like, it's not a time to worry because we've got to get that egg and sperm exposure. I think for a lot of people listening, that actually is a sign of hope,
Yeah.
even when it's been such a long journey.
And I think it's important to review that periodically. Like if I see somebody for the first time and they, haven't had a period in 5 years, and then maybe they go on a GLP and maybe they're starting to have regular periods or lifestyle modifications, whatever it is. Like, I think we have to call that out. Look, your body's waking up. Your body's doing what it's supposed to do. Like, we are getting you in your fertile zone. I think about the fertile zone, right? Especially as related to weight and inflammation. So like, I think, maybe we're not at baby yet. I know you talk about a lot about prepping for baby, but it's like, it's a progression. And we have to call out when we're making forward progress, because sometimes it can feel like, okay, well, every month that goes by, it's not here yet. And time has this really weird way of like having, whether it's a holiday or a anniversary or something where we had hoped things would be different by now. So really saying, hey, I know it's this date, but like, you're now ovulating every month. That's great. We've documented a lot of other things that are normal in your system. Stay the course, not indefinitely, but saying, okay, you need a fair shot at egg and sperm exposure. And then if things are still not connecting, then we can reevaluate.
Mm-hmm.
Yeah,
Yes. Yeah. Would you like to talk about the Escher guidelines?
absolutely. Yes.
Is that how you
So
pronounce them, or do you say
well,
ESHRE?
I say ESRE. I don't know.
ESRE, okay.
ESRE, ESHRE, and it's just a more European approach. And so, like, we were all taught the Rotterdam criteria in medical school. So, like, we talked about the ultrasound criteria, the period criteria, and then the androgenism, like clinical or biochemical. So that's Rotterdam. I think there's limitations with that. I think people have said, well, maybe we overdiagnose PCOS in young women because their follicle counts are naturally high, or maybe there's different pathways to PCOS. Actually, I read an article recently, which I think it was based out of China. It looked at different phenotypes of PCOS and obstetrical outcomes. And it was like the first new thing about PCOS that I'd seen in like a really long time. So that was exciting to review that for Journal Club. But a couple of years ago, ESRI came out with new guidelines for PCOS. And, they actually included anti-Mullerian hormone in the diagnostic criteria, even though they did not say an exact threshold for a high AMH. So, it was kind of nice to see that because that's a blood test. It's a lot easier to get than an ultrasound. They talked about like how it can be really hard to diagnose PCOS in teens. And so, like, really just kind of staying the course and not rushing to a diagnosis at 18, but seeing how things settle out. I think that's really powerful. And I think the thing that was most impactful about those guidelines is that they really took a more holistic approach to the whole diagnosis of PCOS and what that means for somebody's quality of life. It's really the first time people have looked at all the different facets of how people feel on a daily basis that are affected by PCOS. So I think we need to start thinking more holistically about PCOS, and I'm really glad that the new guidelines, sort of reflected that.
Oh, I love that. Yeah, because PCOS is, as we've talked about, there's so many different components to it and
Yeah.
how people are feeling. So, yes,
Yeah.
that's a great advancement.
Yeah, and
And
I mean,
I
I
also,
think
go
yeah,
ahead.
go ahead. I was just gonna say, like, stage of life matters too. If somebody is, you
Mhm.
know, trying to get pregnant, that's very different than if they're in perimenopause or menopause. Like, PCOS is something that it's like a lifelong diagnosis, but it manifests differently at different points in people's timelines. And so just thinking about the reproductive lifespan and how to optimize health at the various points with the various goals. For some people, it's, optimizing their skin. And I know you do mostly like fertility stuff, but like for some people, the acne and the extra hair, I had a patient who was misgendered. It like crushes my spirit when I think about this. She was misgendered because she had so much facial hair that receding hairline, that people truly thought she was a man. And like that's just unacceptable. And she had mental health issues, which I'm sure were partly related with that. And so again, we have to think about this holistically because it really does affect every part of people's lives. And also cancer prevention. I mean, it's not
Mhm.
good to go so many years without a period. Really, people need to be having either a period or progesterone exposure in some way, at least every 3 months to have a period. Otherwise, the risk of endometrial precancer and cancer goes up. And I don't think we talk about that enough. I can't tell you, and I'm sure you have too, like I've just diagnosed so many patients with endometrial cancer, frank cancer, I mean, lots of precancer too, but cancer. And what that does, I mean, it's like, oh my goodness, like, okay, now we got to pause the fertility journey. We can do fertility sparing options, but that can be a
Mhm.
real, just not a bump in the road, but can really rock somebody's life to get a diagnosis of cancer in the 30s. And so, really, just making sure we're touching all the aspects of people's lives and their health.
Yes. Dr. Erica, you just like you have this presence that just feels so comforting. And, thank you so much for the work that you do. Can you share with people how can they find you? Where are you
Yeah.
at? And physically and on the online space, how can
Yeah,
people connect with
absolutely.
you?
So if you're in the northeast of the US, my medical practice is at the University of Vermont, and I also have a coaching practice which is virtual and international. And so I am at loveandsciencefertility.com. And that's the most comprehensive way to find me is my website. I'm also on socials under the same name. So Instagram, Facebook. I'm also on LinkedIn. And then I have a podcast as well called Love and Science Fertility. And I just launched a course starting to thrive through infertility, which is 12 modules and 18 CME credits. And people who are health allied at all, even social workers, can get continuing education credits for the course. And I'm really excited about that.
Fantastic.
Yeah,
Okay, great. I'll have all those links. I would love to link to that episode that you mentioned that specifically is about advocacy.
absolutely.
So we'll have that all in the show notes.
Okay.
So thank you so much for being here, Dr. Erica.
You're welcome, Dr. Angela. Thank you for the work that you do because I just know how many little ones are in the world because of the work that you do. And I also helping people feel better along the way. It's like I always say, like, fertility is not this thing that you like, sort of survive, 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 and then you magically end up at the other end like pregnant, but like infertility has taken everything from you. I just think that model is not working anymore. And we have to look at it like how can we like restore wholeness, restore joy, restore hope, feel better as we're going through this because I firmly believe that infertility should not take everything. It should just be a part of our lives, right? But it does, and there's a different way. And I think your work is a great example of that.
Thank you so much for saying
Yeah,
that. That means a lot.
yeah,
What a beautiful breath of fresh air today's conversation with Dr. Erica was. I hope this episode leaves you feeling deeply empowered to step back, to look at your baseline biology, and give your body the time and space it needs to restore that natural rhythm. Remember, your path to motherhood, it does not have to be a race. And a holistic approach, it isn't just about getting pregnant. It is about feeling good in your own skin along the way. Thank you for being here in the PCOS Lab today. If you are feeling frustrated, remember, your body, it's not broken. We just need to find the missing clues and fit together the right data points. When you are ready to look at those clues, head to drangelapotter.com/start. There, you can choose the exact next step you are ready for, whether that's my ovulation assessment or applying for an audit call with me. Either path gives you the personalized clarity you need to stop guessing and start creating a predictable cycle. That's drangelapotter.com/start. Keep looking at the biology, be gentle with your system, and I'll see you next time in the lab.